The one that was the, oh, it was the one that was the wrong. I think it's the wrong, that's not the,
You can go ahead and click on yours.
it's not it, it's the one from last week.
Okay, so they're supposed to have an update in PowerPoint. Okay, I'm going to. We're waiting on our PowerPoint presentation. Just a few little technology difficulties.
That's the,
Helpful if you have today's presentation, unless you want to talk about all of that budget stuff again. Thank you. Just go to the next slide. Okay, you can just go to, if you can. Yeah. So hello again. Thank you for having us here. A very important topic that we're talking about today. Our home and community-based waivers in Medicaid serve a very vulnerable population. The home and community-based waivers are designed to give individuals who have disabilities an alternative to institutionalization. So therefore, many of the individuals that are in our waiver programs would otherwise be in long-term care facilities. They have to meet a level of care in order to be in our waivers. The services that we provide complement the Medicaid program services that are provided in our state plan. These waivers provide, for example, personal support services, homemaking services to allow those individuals to remain in their home safely and in the community. If an individual needs services that cannot be safely provided in the community, he or she may not be appropriate for our waiver services. So we have 6 home and community-based waivers in the Department for Medicaid Services. We have our acquired brain injury and our acquired brain injury long-term care. This is a waiver for individuals who are 18 and older with an acquired brain injury. We also have our home and community-based waiver services, or home and community-based waiver. It's for individuals who are over the age of 65 and older, or individuals of any age with a physical disability. Our Model Waiver 2 waiver is designed for individuals who are ventilator dependent for 12 or more hours a day or on an active physician-monitored weaning plan for a vent. Our Michelle P. waiver and our Supports for Community Living waiver are very similar, and they provide services for individuals with intellectual or developmental disabilities. For state fiscal year 2019, here are just a few little pie charts that show you the population served and the total amounts paid for the populations for each waiver. So, for example, you can see on the left side our Michelle P., which is the blue waiver. We served 10,212 individuals. That accounted for 39% of the waiver population. The cost for the Michelle P. waiver was $342.2 million, or 36% of the cost spent in the waiver program. And in essence of time, and I know we have several presentations after us, but basically total population served is 26,383 in all of our waiver programs. So the redesign, as you are aware, started in the previous administration, and we agree that this is something that definitely needs to happen. Our home and community-based waivers, again, serve a very vulnerable population. The waiver redesign, one of the big issues when we went to the redesign and we're following through with some of the recommendations was that in order for the waiver redesign to be budget neutral, we would have to change reimbursement rates for providers. For example, we would have to reduce some provider reimbursement rates and increase other provider reimbursement rates. And as you can imagine, some of the providers definitely, likewise, or just definitely had some concerns with that, and rightly so, because we have a population right now that we're serving, and in order for us to continue to provide those services and align provider reimbursement, it would be about an additional $43 million, we estimate. So in order for us to go through with redesign, we're going to have to either have additional money, or we're going to have to find a way to find some efficiencies where we can. And I think right now I will turn this over to Pam Smith and let her talk about some of the activities, why we needed to redesign, and some of the activities that we have taken thus far. Pam?
Thank you, Commissioner. So first I want to talk about our wait list, because that seems to be a topic that comes up over and over again. But I want to give you some additional information behind the wait list. So as you know, Michelle P. is our largest wait list. We're up to over 7,400 individuals, with an average time being on that wait list of 3 years. The longest an individual has been on that wait list is 6 years. We have actually allocated 350 individuals already since January, and we'll be allocating another 175. Those are actually in the process of going out right now. For SCL, it is broken down, of course, into 3 different categories. One is the emergency category, which means the individual needs services right now, or they either are institutionalized or are going to be institutionalized right now, that there's no safe alternative for them. We have 0 on that waiting list and have been able to maintain that for quite some time. Our urgent category, there's 121 people on that. Average right now is about 3.6 years that individuals have remained on that category. However, at any point in time, if something changes, they're able to move up to, they are able to request that emergency slot. The future planning is more for individuals. A lot of times you'll have a child, even a toddler, that will request to be placed on future planning, or a young school-age child, because they know at some point in time in the future they are going to need services, but they are not needing those services at this time. But just because someone's on a wait list does not mean they're not getting services today. So just some other statistics about the wait list. So for Michelle P., the average age of the person on the wait list is 16. And 73% of the individuals are under the age of 21, which means that they also are available. They can get state plan services. They can get services using EPSDT. 5,800 of the individuals on the wait list have Medicaid eligibility, so they are accessing some type of services, and an additional 143 actually have Medicare eligibility. The average age of an individual that does not have eligibility right now is 15, which likely means they could be receiving private insurance through a family. For SCL, 90% of these individuals are already getting services in another waiver. So those might be that's in the urgent category and future planning. So a lot of them are already receiving services through Michelle P., some of them through HCB, and are getting their needs met. All individuals on both categories in SCL either have Medicaid eligibility currently or have Medicare eligibility. And we have issued 13 slots, allocated 13 slots since January 21st in SCL. So again, speaking to why do we want to redesign the waivers. If you can look at Kentucky compared to the rest of the United States, Kentucky outpaces the national per capita average spend for our waivers. We spent over $1.5 billion on these waivers in 2016, and Kentucky has continued to outpace the growth of national spending between us and the other states. We grew nearly 20% in 1 year between 13 and 14 alone. We're ranked 19th in volume, so the number of individuals that we serve compared to other states. And we are ranked as the 26th most populated state. So next slide to look at. Again, this is comparing. So we spend more than 40% per capita on people with developmental disabilities compared to the U.S. average. We spend 43% less on our older individuals or people with physical disabilities compared to the U.S. average. And this really speaks to the concept of the haves and the have-nots when you look at it by disability population. And so one of the things that I think is most important to stress to this group as we look to redesigning waiver and how to fix waiver is that we can't look at it with certain disability groups in mind. All disability groups should have equal access to services and should have equal opportunity to age in place and to remain integrated in the community and make those choices. So what are our goals of the redesign? Top one is to enhance quality of care to our participants. We're going to do this through implementing consistent definitions across waivers. Right now, if you looked at a service, respite, or personal care, for example, it has maybe 5 different definitions when really the basis of the service is the same. The individual you're serving may have slightly different needs, but the service you're providing to them is basically the same service. We want to look at a universal assessment and individualized budgeting. That will help us with a couple things. Individualized budgeting, once we get to a view that's not everybody gets a certain menu of services, or this is, I'm going to be on HCB, so this is my service menu, this is what my plan looks like. And we get down to, this is my personal choice as an HCB or an SCL or an ABI waiver member. This is my menu of services I can choose from. These are my needs. Here's what waiver can meet. Oh, but here's what natural supports can meet, and here's what state plan can meet. So until we start taking that individual person-centered view of the individuals and looking at them holistically at what kind of supports they have in their life, what waiver can provide, and what state plan, in some cases private insurance can provide, it will be a barrier to making improvements. Cost containment. So that looks at the services and where is the best place for them to get them, where is the most cost efficient, but where they're not losing anything. It just is the most appropriate place for them to get services. Ultimately, to be successful at all, we have to diversify and grow our provider network. We are in a crisis right now with workforce. It was here before the pandemic. The pandemic has definitely put a more spotlight on it. We can add slots, you can add services, but if you don't have providers to provide those services, you're still not going to get anywhere and we'll be in the same spot. Looking at provider funding. So you shouldn't have one waiver that can get paid $20 an hour for providing personal assistance when another waiver is paying $11 an hour for the same service. Until you have consistent provider funding that matches the services that are being provided, you're not going to be able to have a robust provider network. We also want to optimize case management to support person-centered planning and abide by the federal conflict-free case management regulation. We have found, although it is getting better, but we've still found person-centered is still something we need to work on in Kentucky. It should really be about what that person needs and what they want. What do they want to work on, not just you're on a waiver and here's the services that we think you need. So to talk about what we've done so far, or what across when Navigant was here. So we started in 2017 and did through procurement to get who ended up being Navigant to be our to lead us in waiver redesign. That contract became effective in April of 2017. In August of 2018, the final assessment report with the recommendations were issued by Navigant. So what have we done so far? We've implemented ongoing stakeholder engagement process. I think this is one of our most important steps. We need to hear from our providers. We need to hear from the people that we serve. We need to hear from the people that are on wait lists. These decisions are important and should involve them, and they should have a voice in this. We've switched service authorization from a third party to the cabinet and to case managers. This has allowed for the plans to become more patient-centered. We had reports that case managers were afraid it would get denied, so they just requested the max of everything, whether somebody needed that or not. So we're seeing plans of care that are starting to become more tailored to the individual. We streamlined incident reporting and moved to the electronic reporting system in the Medicaid waiver management application, and we continue to enhance that. That became mandatory to use in December of 2020. The providers, I believe, really like it. It gives them better insight into it, as well as gives us a very strong and quick insight into when an incident report comes in and we need to take action, or we just need to monitor a situation. Training for providers, case managers, and internal staff, that's an ongoing development. We continue to work between us and our sister agencies to ensure training. We're looking at ways to enhance that and to make it better. We've expanded the Medicaid waiver management application access to all providers. So this allows even service providers now to come in and see the individual's plan of care. They can, on demand, generate their own authorization letters. They can look at what the case manager put in as goals and objectives. They can look at when the last time was a service was billed, how many units are left and how many have been used. We updated the patient liability calculation. Prior to this change, patient liability was calculated at 100% of the federal benefit rate, which ended up we had members having a patient liability to access their waiver services of, excuse me, I'm so sorry, from $1 up to some of them over $1,000. We updated that to 300% of that rate, and so now we have less than 20 individuals that actually have any patient liability to access waiver services. And we did complete a comprehensive rate study with recommendations for a new rate methodology. I apologize so much. My allergies are really getting me today. We also, in November of 2019, operationalized a waiver help desk. This is staffed by staff in my division. They speak to members, they speak to advocates, they speak to providers. We have a specialized group that deals with case managers, so if they're out in the field and they have a question, they have somebody that they can call and directly get to speak to. And we receive anywhere from 45 to 80 calls on that line every day. We've developed resource materials for providers, participants, and internal staff. We've developed a lot of quick reference guides, which we have found very helpful. We've had participants and other advocates help us with those. That really helps whether you're a provider or a participant to know what comes next. What do I do next? Okay, I've been given waivers, so what do I do next? We've started looking at planning and implementing some of those MWMA enhancements. One of those is what I had mentioned earlier with incident reporting and with all providers having access to MWMA. We formalized the grievance and appeals process and moved reconsiderations to an independent third party, which is the Cabinet's Office of the Ombudsman. So now when a waiver service gets denied, that reconsideration actually is viewed by someone that is not part of the initial process. We've introduced updated service definitions, policies, and procedures that are in the home and community-based and Model 2 waiver renewals. Those are currently in the process of going through. They both recently expired, so we had to do renewal applications with CMS. And so those Model 2 actually will be resubmitted for the final time tomorrow. In HCB, we are still responding to CMS's comments. So key takeaways. Our programs serve a diverse range of ages. We have a lot of pediatric patients. Statewide enrollment does not reflect the population density, suggesting there's access gaps, particularly in rural areas. That points to a lot of our issues with having providers, and our wait lists remain an issue. However, I am proud to say that for both ABI waivers, we no longer have a wait list for either one and have been able to maintain that now. So what do we need to do? We need to look at what the shortcomings are in access. We need to look at how do we better design the programs to serve the pediatric populations that we're seeing, and identify strategies to better utilize limited resources and to get individuals off the wait list in the absence of increased funding. going to highlight some of the findings from the Navigant Assessment. Their assessment involved review of the waivers, all of our regulations, all of our internal processes, and they also conducted interviews with cabinet staff, and that included us and our sister agencies, the Department for Aging and Independent Living and our Department for Behavioral Health and Intellectual Disabilities, as well as they went out with us and helped conduct 40 external stakeholder focus groups. So we met with the individuals directly, their caregivers, advocates. They found 49 findings across 10 areas and made 11 recommendations to address those findings. So the findings, and I don't think these were really a surprise, and I don't think they'll be to you all either. We've talked about these, is that we need to update our waiver applications and our administrative regulations. We need to look at a validated assessment tool that better gets to individuals' needs. We need to look at how we're allocating services and how that can be done more efficiently and strategically. We need to look at payment and rate setting, case management and person-centered planning. How can we do that better? How can we support our providers better in doing that? And then also looking at not just our waiver service areas concerns, but our non-waiver concerns. So individuals knowing, we repeatedly hear, they don't understand what they can access through regular Medicaid. So making sure that they understand the other services they're eligible for, not just waiver. Stakeholder engagement will continue to be a foundation of what we do. I think that it's vitally important that we hear from all stakeholders, whether it's internal, it's our providers, but most importantly, it is our members and the individuals we serve and the individuals that we hope to serve. Looking at our waiver quality measures, so not just we're going to put these changes in, but how do we measure, are they effective? Are they working? Did we do what we thought we were going to do, or did we need to go back and start over or modify that we did? Our waiver configuration, does this work today, or would something different work better? Talking to other states, looking at how other states structure those waivers to see if there's something we can do there. So we've talked about standardizing definitions, but also looking at provider qualifications so that it's easier as a provider to serve in more than one waiver, so that I don't have to have a set of qualifications for the same service in 5 different waivers. Move to need-based care planning with the universal assessment tool that's completed by an independent entity. So that again drives towards getting the right services and the information to support those services. Talking about the budget process, looking at how can we modify that to make sure again that we have individuals that are getting the right types of services that they need. The rate setting methodology, looking at the cost that providers incur to provide services to individuals, what it costs to serve them, and really to have that methodology so that we can have a strong provider group. And continuing to work on our standard operating procedures internally so that anytime there's a question about how something is done, there's always a document that is reviewed annually that will give someone guidance into why decisions are made and why we operate the way that we operate. We want to update the case management approach for waivers. We want to continue to develop tools for them and performance standards and training that better reinforces and supports case managers. Case managers really are the team lead when it comes to waiver. And we want to make sure they understand how can they lead those team meetings, how can they facilitate connections with providers and with services. Participant-directed services, or PDS, is very popular in Kentucky. We have probably about 60 to 70% of our individuals that access at least one participant-directed service. So we want to look at how do we streamline that? How do we reduce the disparity between which FMA that you're using, and really how to support those FMAs and strengthen that program. Participant-directed services will continue to become even more popular as we have less and less providers. That really fills in those gaps when we don't have a traditional provider. We want to continue, as I mentioned, the ongoing stakeholder engagement process. We want to talk about that we have one quality management business unit, and that really it would be you have representatives from every unit in the cabinet that has a place with, so it would be individuals from DMS, it would be individuals from Dale, individuals from BDID, and really anywhere that touches a waiver participant, so that we have a holistic view of the quality and that everybody has a seat at the table to try to make improvements. We want to implement a quality improvement strategy, looking at outcomes and participant experience. So again, focusing on the quality and measuring what we did it make a difference, or do we need to go back to the drawing board? And then in the future, looking at, is there a way to reconfigure the waivers so that it would serve more people, or that possibly would be more effective, or that would allow us to do more things? So some additional concerns that weren't included in the assessment report. The workforce issue, as I mentioned, it touched on this, talking about finding, the streamlining the qualifications, and it looked at that. But we just recently did a survey of our providers, and 42% of the providers who responded reported they have little to no response with job postings. 41% responded to having issues finding applicants who are qualified, meeting hiring eligibility requirements, and that have the work ethic needed to perform these services. I just heard on one of the national groups that we're a part of that right now vet techs, so people that take care of pets, are making more than what our individuals that are taking care of our loved ones and our most vulnerable population are making. PDS background check cost. Right now, the potential employee and other interested third party or the participant themselves is paying for the background check cost. We are looking for ways to change that and to improve that, so that it is not a barrier to an individual that wants to choose participant-directed services as their delivery method for services. So what actions are we prepared to take? Initiating waiver renewals with updated waivers and regulations that implement rates based on a sound rate methodology. Improving case management performance while implementing stronger utilization management methods. Further reinforcing participant-directed services design and operations. Retraining on our current assessment tool, and updating our independent assessor contracts to promote valid, high-quality needs assessments. And evaluate options for a risk-based waitlist management. So how can you help us? So of course, the number one thing is going to be funding. We need money. So I think several of you have heard me say before, if somebody shows me where the money tree is, I'll go and shake it. But funding is going to be key. But also, and this is the one thing that I really these last two that I want everyone to remember, is that holistic consideration of HCBS. Remember that we serve a variety of populations, and that each of these should have equal opportunity to receive services, to be in the community, to age in place, and to be community integrated. We need public support for updates. So we do anticipate some pushback from stakeholders. Change is hard. People don't like change. So we anticipate that we're going to have some people, just because we say we're going to change something, that they're automatically going to have an opinion or an issue, even if sometimes themselves they're not even sure what that is. The hot button issues, of course, will be surrounded rate setting and the participant-directed services policies. So I'll pause there for any questions.
And if I could add, we know that the waiver population serve a very vulnerable population. It's aged and individuals that would meet nursing home level of care. We do know that it is cheaper on the aggregate. It is cheaper to serve individuals in our waiver programs. In the event that we could start moving individuals from a facility into a waiver, there would be some cost savings. However, we have to look at the fact that we do have an aging population in Kentucky, and it's only going to increase. So when we move an individual out of a facility, that bed is going to be backfilled. So as Pam said, the funding is going to be critical for this going forward. We want to serve as many individuals in our waiver programs as we can. We want all individuals to be in the communities. We know there are some issues with our waiver programs. We feel like that we have worked on a lot of those issues and are more than willing to sit with our stakeholders to continue to improve these programs. But again, the overarching issues are access to those services, the provider network, and funding. Definitely is going to be one of the issues that we need to tackle. So we'll be more than happy to answer any questions.
Thank you so much.
Senator Parrott, can I make a comment?
Yeah, go ahead, Senator Parrott. We have several questions. Go ahead.
Okay. I heard that there were 78 added each month. My question is, how many go off each month?
I don't have the number directly in front of me. That's something I can get for you all.
Okay.
But I will say that it's not a lot, because the individuals these are chronic health conditions, and usually we see individuals that remain on the waiver for several years. But I can get that information.
Okay. Thank you.
Thank you, Senator Parrott. Senator Meredith?
Thanks, sir. Appreciate it, and a nice report. Thank you, folks. Did a very good job. I think your most telling slide is probably number 8. You talk about 40% more per capita on people with developmental disabilities compared to U.S. average, and we're spending 43% less per capita on older people. So in summation of your report, what we're really trying to accomplish with this is, one, better utilization of resources than what we're presently doing, and I think that's quite evident. But secondly, be able to provide services to those who currently are not able to access those services. That's the backlog and the maldistribution of the dollars, as you noted on this particular slide. Is that a fair summation of this?
Yes.
And Commissioner, I appreciate your comment about, even if there's a savings, and that's a very loose word, on the utilization of resources, that because of the pent-up demand that we have for these services, probably that's going to be consumed, whatever savings we do realize. But I think it's important going forward to recognize where those savings are coming from, because that's a reallocation of dollars as well. But you threw out the number, you need an additional $43 million. Do you have any specific breakdown on those dollars as to what that $43 million is comprised of?
Yes, in the previous redesign, we were looking at a redesign with the rates and being budget neutral. So all waivers have to be budget neutral. We have to spend as less or as equal to we would if an individual outside of that waiver. But in the redesign budget neutrality, one of the recommendations, or one of the statements, was in order to align payment across provider types, we would have to take funding or reduce reimbursement to certain providers and increase reimbursement to other providers, which basically resulted in, robbing Peter to pay Paul, and there's going to be winners and losers. So that was one of the biggest reasons for the redesign, or for the pause on the redesign, because if we did not do that, if we just brought all other providers up to the highest level of payment reimbursement for the other provider types, waiver provider types, it would be we would need an infusion of $43 million to do that, in order to balance that out without reducing reimbursement to one waiver provider type.
I appreciate that, and I can be supportive of that, but I think I'd like to see a little bit more refinement of the numbers. I think we need to make a projection as to how much it's going to cost to provide the services of those in waiting, what the projected savings could be. And I know that's a very tough one to come up with because it's purely speculative, but in order to really understand the full scope of this, it's almost like a revised income statement. I need to see those numbers so I exactly know what the net effect is, and I'm not sure I understand what that is now, but I do understand the need for the redesign, and look forward to the work going forward. Thank you, Mr. Chair.
Thank you, Senator Meredith. Senator Adams?
Thank you, Mr. Chairman. Listen, I just kind of want to get a sense of where we are overall. And that is the cabinet going to move forward with the Navigant study? Are they moving forward with their own initiative? Are we, what is the likelihood that when we talk about recommendations that, that this current administration is actively moving forward on recommendations, or are you moving forward on your own plans?
So we have moved forward with recommendations that do not have a major impact, that we feel like that we could get some really quick wins. The one thing that is holding us back from moving forward from some of the Navigant recommendations is funding. And we'd be more than happy to bring the funding information as that Senator Meredith requested. But currently, we are in a holding pattern, and we have not made any recommendations for going forward outside of the Navigant report.
Okay, thank you. Yeah, and I'm with Senator Meredith. I would like to echo his comments that I think that it's important that we talk about funding in more specific terms so that we know what our task is once we reconvene in January, and we have that real solid, comfortable breakdown for everybody. Thank you very much for your testimony.
Thank you.
Thank you, Senator Adams. Representative Kirk McCormick.
Excuse me. I'll just say that I have a strong background in working with people with disabilities, and I see the advantage of keeping children and adults in the community and in their homes, if at all possible. I would love to be able to talk to you more one-on-one about the needs. I'm a big supporter of these programs. So I saw firsthand for many years as a rehabilitation counselor with people with disabilities, the critical need for these services that's being provided. I also have personal knowledge of how hard it is to find employees to come into the home and be a caretaker, to allow parents respite or allow parents to work. So there's just these programs are awesome, and when I worked in the field of social work, these programs weren't available. So it's come a long way with the waivers and everything. So I'm a big supporter of them. Let me know what I can do to help you and how we can improve some of the things that you've talked about, including tapping into I always called it a hidden workforce. And that's that there's a lot of people that don't know about these jobs, and then the individual that is recruiting, for example, a parent or a guardian or whatever, they usually just reach out locally trying to find someone to employ in one of these positions. So actually there's some pretty good job opportunities for individuals, and it's much easier to work as a personal care attendant in a home than it is to work in a nursing home, or skilled nursing facility and have 60 patients to take care of. So I think there's a big selling point to that. Also, I would suggest recruiting maybe some CNAs through CNA classes because they've got basic nursing skills that would be very handy. And I'm familiar with your program because I know people that's participants in these waiver programs. So I commend you for the job that you're doing. Feel free to reach out to me. Thank you.
Thank you so much. We know that these programs provide such a valuable service. And again, the Medicaid program is the go-to program to solve these sorts of issues that is very difficult to solve, because we are the only agency that covers waiver services for the particularly personal support services and homemaking services that allow individuals to stay in their home. We know that there's not another opportunity or an organization that covers those types of services, and we know how important it is to the population we serve to help them stay in their home. We know that we're going to have some very difficult conversations going forward on how we redesign and keeping in mind that we're all here for the same reason, and that's to improve the quality of care that individuals are receiving. And that we want that to be at the forefront of all of our services, is the member comes first, and what sort of quality are they getting in those in their programs that they're receiving right now, and how can we improve that quality and improve their overall quality of life while they remain in the community.
Thank you, Representative. Senator Carroll.
Thank you, Mr. Chairman, and Commissioner and Pam, thank you both for being here today. And I'll try to limit this. We could probably have a 5 or 6 hour conversation on all this, but I'll focus on just a couple specific issues. One thing that I've never seen is a breakdown on the various services, whether it be CLS, respite, with all the services involved under these waivers, a breakdown on how many hours. And have you all done any studies in relation to those services? Have you identified particular services that might be the greatest area of savings? And I think you're right. There are a lot of times that services are granted that really aren't as specific as they should be. There may be more services granted than what's really needed. So I do agree that that's something we need to look at, but it would really be good to understand throughout the waivers how many hours of each type of service is actually being utilized, and looking at that. And are there lessons to be learned from that? Have you all done anything of that nature in the past?
We do look and analyze services that are being delivered across the waiver programs, and I think that would be something that we could definitely bring to this committee when we start talking about the budget and the funding that Senator Adams and Senator Meredith were referencing. I think that it would be a really good exercise to look at what the payments are being made across the waiver types for specific services. I think that will help us move forward. Make some decisions as we move forward.
And it is it's going to be an almost impossible balance. I'm not going to say difficult, I'm going to say impossible, because there is a need to be more efficient in the way we provide these services and the way we distribute the services. And I agree with that completely. But then there's the other side of that is the provider side of it, where many providers across the state are barely surviving right now, not even getting to the workforce issue. But it is difficult to balance all of those things while we are trying to be more efficient. And the goal does need to be to provide as many services for as many people as we can as they are needed. So completely support the operating more efficiently, but financially, we do have to be aware of the providers and making sure that there are services available throughout the state to provide whatever services are approved. With that being said, one other thing I want to get into, and I don't want to spend a lot of time on this because I know we need to move on. For 11 years now, I have struggled to understand the process for bringing people on to the waiver. And I'm going to ask you one more time, if you would please, Pam, either you or Commissioner, walk me through this. How many people let's just stick with Michelle P. How many people are there on Michelle P. right now?
So right now we are at about 10,200 or 250. We're close. We're within 200 or 250 of that cap of the 10,500. It fluctuates a little bit day to day, but we're right in that range. And so we still, when I came on in this position, we've been allocating for Michelle P. every 90 days for at least the last 2 years. So part of that was originally to get on the Michelle P. wait list, you had to fill out a form and that was it, and you got added. So it has taken us a while to get through a lot of those applications where the individual sometimes didn't even know what they were signing up for. We're also finding a lot of times that by the time their number comes up, they've either been enrolled in another waiver, they've moved out of state. That's why we're getting ready to do that next 175. And so we will get as close to the 10,500. We always reserve between 30 and 50 slots for individuals that lose their services through no fault of their own. So something happens and they lose Medicaid eligibility and they need to work through that. Or a lot of times they were admitted as a child, and now that they've crossed the age threshold that they actually need a disability determination, sometimes that can take a little while. So we always will reserve 30 to 50 slots for that, so that we could bring somebody back on and not be right at our cap. So we won't go up to that 10,500, but we're going to get at least to, our goal is to get to at least 10,450.
Okay, so the number on the waiting list has not declined, it's increased every year. How many have we purged from the waiting list due to ineligibility over the last 3-4 years?
I can get the number for you.
Is
I'm not
it-
sure
is
off the
that a
top of my
substantial
head.
number?
It is a substantial number. Yes, there are a lot of individuals that we can't find. There's a lot that I can get that number for you. I just don't have it off the top of my head.
So let's assume, let's say there are 10,000, and let's say during a given year, and I'm just for discussion, I don't have any idea what the numbers are, and that's really not important. But let's say that 500 people on Michelle P. Waiver pass away in a given year. I'm assuming that those slots are recycled.
They are. So the way that it works with Medicaid or with CMS is those slots are unduplicated. So our waiver year for Michelle P. is September 1st to August 31st. So even if an individual passes away, if they utilized one service within that date range, that slot cannot be reused until the next waiver year begins on 9/1. But every year, beginning September 1st, we will take all of the slots that have been vacated. So somebody, moved from Michelle P. to SCL, they moved out of state, they passed away. All of those slots then get reinfused into what's available.
Can you all give me the numbers for the last 5 years?
Last 5 years.
For each year on how many slots were vacated? And so those slots are filled, and then whatever number of slots that we approve through a session, those are added to those numbers.
We have to submit them to CMS for the approval too, but yes,
Okay.
then those would get added.
And the standard, the reimbursement, it's 70/30, correct?
Yeah.
Okay. And I struggle to grasp this 3-year average waiting period because I simply don't know of anyone in our area that's getting approved, and that's been a struggle that we have had for years. And I know people that have been on the list, many that have been on the list 5, 6, 7 years. So I struggle with this 3-year average. I'm not sure I agree with that.
It's a lot of it is the people that fall off. So the people that, when we do every year, we do an annual wait list update where we send out letters to every single person on the wait list that say, are you still interested on staying? If you are, do you need to change your contact information? So we have some people that come off through that process too. So
it's not truly that you're eligible and you only wait 3 years and you get it.
That's
right kind now, of a misleading number.
Okay. Right now, what we are in, I believe mid 2015 is the date that we're allocating from. Right now, so it's about 6. So we're at the 6-year mark. The slots that we're allocating right now, those individuals have been on.
Okay, back up. Explain that.
So
please.
So they get placed on the wait list by whatever date they submit a complete application. So the slots we're allocating right now were applications that were submitted like in June. I think April, May of 2015. I'm sorry, 2015. We've made it through. The wait list actually started February of 2014. And so we've cycled through all of 2014, and we're up to about mid-year of 2015 of individuals.
So basically you're still 7 years behind?
We are, yes.
Okay, that helps to put it in perspective. But that statistic's a little misleading. I would ask that you all change that.
Okay.
And be a little bit more detailed in that. Mr. Chairman, I'm going to stop there. I could go on for a while. Thank you. Thank you all for your answers.
Thank you, Senator Carroll. And I've got a real quick question I'd like to ask. If you go to slide 7, it indicates that Kentucky has outpaced the growth of national 1915C spending. And then we also rank 19th in volume of spending of all states. And this ranking outpaces our space is the 26th most populated state. Do we have a higher percentage of our residents that have disabilities than do other states? Is that one of the reasons for this?
We do have a large, especially in the pediatric population, but I can get some more information on that and can give you, I don't want to speak to it just off the top of my head, but we have the data and I can get that and can share
Okay,
it.
I would appreciate that. Thank you, and I don't think we have any more questions. Commissioner Lee and Director Smith, we appreciate your testimony today, and I'm sure we'll be hearing more from you in the future. Thank you very much. Now we will hear from several 1915C home and community-based waiver services advocates. Our next presenter is Steve Shannon, Executive Director of the Kentucky Association of Regional Programs. Mr. Shannon, please make your way to the table. Once you are ready, please introduce yourself for the record, and you may proceed.
Excuse myself to run to the restroom real quick. Okay. I may have to do this. Okay. It's right after lunch.
Oh, geez, oh, Pete. Who turned that off? I'm going to blame Pam Smith for that.
Steve, I apologize. We're going to need you to start over because your microphone wasn't on, so we don't have it for record. I apologize.
All right. Again, I'm Steve Shannon. I'm the Executive Director of CARP's Association of Community Mental Health Centers, 11 of the 14. And this slide, just so informational, you know who your CMHC is locally. So you know who those are. And hopefully you all know who those people and what they do. The CMHCs, again, there's 14 of us. CARP's Association 11. We serve about 175,000 people annually, 8,000 people employed by CMHCs. If you throw in the PDS piece that we do payroll for, that number escalates. Wide range of folks, direct support professionals. We have physicians, lawyers, doctors, therapists, 300 volunteer board members. I point that out because we are community-based and we are led by dedicated volunteers in their community. You know, I say CMHCs make all communities better in Kentucky, and I believe that. You've seen this slide already. These are the 6 HCB waivers we currently have. There's an 1115 waiver for people with substance use disorder that's pending. Hopefully that happens if folks are incarcerated, and hopefully that does take place. My question to you is, what is missing from this slide? Hopefully you've heard this before. Bing, should have a drum roll for that. Individuals with severe mental illness. I first testified of this effect in June 2019 at the Interim Health, Welfare, and Family Services Committee. And that testimony clearly, at that point, we laid out the need for an SMI waiver. Should be noted, the Navigant report, one of the public comments they received, was a need for an SMI waiver as well. People are severely mentally ill in Kentucky. There's a task force on this issue. Senator Meredith serves on that task force, met last Tuesday. I will present on that information in July on the waiver again. I I want to point this out. This is off the Navigant report data. About 24,000 people, $857 million, $35,500 a person, $0 to people with severe mental illness. There may be some who are in a waiver, but not because they are severely mentally ill. Not because they are severely mentally ill. It's because they have an intellectual developmental disability, have a physical disability, maybe elderly, may have acquired brain injury. $0 spent on that population in Kentucky. It's about time we change that. Nationally, it's $12 for every 10,000 waiver dollars go to people who are severely mentally ill. I think it's time we make that change. Other states have a waiver, so one of my recommendations is an SMI waiver. Any group that invites me to speak, I'm going to lead with SMI waiver. Residential services, people need a place to live. We have a staff residence model, group homes, in-home supports, medication administration support. I point that out as a service because if you're in a waiver today, and if you're an hour late for your medication, a multivitamin, or aspirin as a blood thinner, that gets documented. If you're mentally ill, severely mentally ill, if you're an hour late, a day late, a week late, a month late, nobody knows. Nobody knows. The first person to find out, family members probably know, they'll tell you. Neighbors, law enforcement. Just doesn't seem right to me. Supported employment, help people get work. There's some state general fund dollars to support employment, some grants. Service some states have is tenant skill building. And this is really to teach people who rent an apartment how to keep an apartment. People I've known who are mentally ill get evicted quite often, maybe dirty. They don't maintain it. They don't pay their utilities in a timely manner. We had one guy on our street who got an apartment, and he was told by his case manager, pay your utilities on time. He was at my house for my wife to write a check in his checkbook. We didn't pay for it. She helped him do it, with money for a stamp before the mailman left our street. We only have about 8 houses. He got it. Not everyone's that good. A lot of folks in personal care homes with more supports could live in the community. SMI waiver number 1, in my opinion. Briefly, past redesign efforts. Navigant, heard a lot about it. But before that, there was a started by the cabinet as well. The commissioner, the Dale commissioner led. We met 3 times. That ended abruptly. So we've talked about redesign before. Navigant report again, heard it earlier, 49 findings, 11 recommendations, and a rate study that was done. I think that's the controversial piece, the rate study. I'm going to be a little different than my predecessors. I support budget neutrality. Budget neutral is a concern for me. Budget neutral, when I define budget neutral, it's we spent $857 million on 6 waivers. We want to redesign and still spend $857 million on waivers. You can't do both. I don't think there's enough efficiencies within waiver delivery to create sufficient dollars to move the needle on redesign. Heard it before. 3 of the waivers lost money, 3 picked up money. You will not hear from the winners. They will not call you and say, wow, this is awesome. We're getting more money. My friends behind me with the ABI waivers, they'll tell you more about this. They lost $1 in $7 that they had allocated previously on the rate study. 1 out of $7, 14.25%. That's pretty hard. Michelle P. lost some money on the rate study. Model 2 picked up, SCL picked up, and HCB picked up. So I think, and when that document, when I first saw it, because I was on the rate study work group, and I saw the migration, I said, I'm assuming phones are ringing right now because those dollars. So the task to Navigant and previous waiver work I've done, we can do whatever we want, but we can't spend more money. It just doesn't work that well. I think we've proved to ourselves repeatedly that that's problematic, and I just don't think there's sufficient efficiencies to create impactful change. So we got to evaluate budget neutrality. I think we got to review the existing recommendations. You heard about 11 of them today. Keep at that. SMI waiver. I'll keep throwing that out all day long, just so we all know. I like the message early, report on outcomes, focus on outcomes. I think that's a better service delivery as opposed to outputs, forms completed, things like that. What are outcomes? I think a real outcome is workforce stability. What's your turnover rate? Too high. We need to look at that. We need to keep people in place. We need to give people an opportunity to make jobs. One point in my life, I ran an agency. I knew when my staff person visited a married couple that worked at Kroger's bagging groceries. They were an intellectual development disability because they made more than my staff person. It was about a 17-minute drive from their home to my office, and I knew what time they left. Because people came to me immediately and said, they're making more than I am bagging groceries. You need to focus on outcomes. I think that's a real outcome. I think health is a real outcome. Let's focus on checklists and forms. We need assistance. I represent 11 providers. We need funding today. I mean, we're really concerned about our ability to be competitive in the marketplace and hire people. And if we can't adequately staff with competent people, we're not in a position to go forward with waivers. And we've talked around this a lot. I agree with Senator Adams. It's time to take some action. We need to figure this one out because we're just not competitive in the marketplace. We got some great people. Senator Carroll, you probably experience on a regular basis. Great people who leave your agency because they can go someplace else and make more money. It's a real concern. We're setting ourselves up really to fail if we don't do that. Got to look at the costs. Got to look at costs going forward with inflation. We talk about a career ladder. People want to get a raise annually. We need to make sure that's built into the system. One is PDS, Participant Directed Supports. From my perspective, it's a great service. Hire people that you know, do really personal things for you. We support that. I represent 10 fiscal intermediaries. We cut payroll for people, millions and millions of dollars of payroll for people. And one, and I got to say this, it's an interest-free loan to the Commonwealth because we get reimbursed afterwards. These are not our employees. We are an employment agency, essentially, and doing payroll. It's a real stressor on agencies to make that work for them. I think using MWMA with PDS would help. I have some people express concerns about that. But it's $100 a month. We're not getting rich off this. If you have enough people, you may break even. But we're cutting checks for people. We have recoupments for services, and our support broker gets recouped. It's gotten better, but we get recouped for those services. So it's a real hard, it's financially stressful. At a situation that Pam helped us with last week with someone, you know. And we're now doing it for HCB waiver, do it for Michelle P. and SCL. We were asked to join those as the fiscal intermediary. We didn't propose that as a model. They came to us years ago for the SCL Michelle P. and the last 6-9 months over the HCB. It's a real concern for us. So we got to look at that. I think it's a great service, supporting a lot of people in the community, doing great stuff. But how do we make sure that, one, the fiscal intermediary, cutting checks, isn't at risk of losing those dollars? I also think we got to talk about redesign across, what can we do across all waivers and smaller pieces. Kind of heard earlier that the SCL and Michelle P. waivers are linked, serve a similar population. Does it make sense in one strategy to focus on those things initially? The ABI, there's 2 of them, focus on those things because they may be more similar and the redesigned system may be different than it would be for across all 6 waivers at once. So focus on those specific things, pull in expertise around those areas as well. Now, one thing did happen, consistent language across all. That's Navigant recommended that. Medicaid's done that. Kudos to them. It's really beneficial because now families and individuals understand what it means. Previously, it wasn't clear. It wasn't clear to me, and I've been at this for 25 years. But now it's clear. So that's a step in the right direction. But are there SCL and Michelle P. things that we ought to pay attention to? Michelle P. does not have a residential option. SCL does. Could Michelle P. be a feeder to SCL? We need residential, you go there. I don't know. It's really hard, but I think we got to look at those things. Maybe set across all 6 for everything, focus on those specific things that are related, and do those things going forward. An assessment tool. I said this last year to you, Chairman Riley. We need to have an assessment tool to identify people's needs. There's one. I don't know if there's a universal tool across all 6 waivers. Maybe there's an introductory tool across all 6 waivers. Then you go for the IDD population, a different tool. My friends from the ABI can probably answer that better than I can. But we need to have a tool that measures acuity. You need acuity to really determine that what people's needs are, and you have those services in place. It also becomes a planning tool. If you have some idea what to expect, you can better budget going forward what those needs are. Who's coming up next? People who really have greater needs, they're next. They're going to cost us more money than someone who maybe next in line has less support needs. So we need to have that piece as well. Got to address the waiting list. Been at this for a long time. SCL has 3 that has that acuity base. People greater needs move to the top of the list. Michelle P. does not have that. It's chronological. You know, if you got on the list early on, you're in the pool. If you're not, you're going to wait a long time to get those services. Is there a way to address those waiting lists to give people an expectation that there's some hope of getting services as opposed to waiting for a long period of time? Some expectation. How do you do that? Some idea. I also think the system needs to be predictable, flexible, and address the needs of consumers first. I think that's key. But if you do that and you take care of providers, funders, and policymakers, I think we'll be okay. But I think we need to look at that, start out with the consumer needs, and build a system from there. This, I like a 2x2 grid. There's only 4 bits of information I have to keep up with, and that helps me. But if you look at this, on the y-axis is change, design. On the x-axis is dollars. I think we're in the bottom left-hand quadrant right now. Low change, low redesign, low dollar. Status quo. I don't believe we're satisfied with the status quo, or we wouldn't be here now. We'd be figuring out what happens next. So that's where we're at, I think. If you go above it, I think what we've done to date is high change, low dollar. Not less dollars. I mean, we're not moving the dollar needle, right? And that hasn't worked so far, right? Navigant, it didn't work for them. Didn't work previously. Other things I've been involved with, we can make changes, can't change the dollar. So I think we got to have a real conversation about what those costs are. And the $46,857,000, that's about 5%, Senator Meredith. 5%. Not a whole lot of money, but got to find it. I understand that. Bottom right, low change, high dollar. I think the system today, without change, is in a dollar crisis. I don't believe we're going to be in a position to maintain our workforce, keep the good ones. Okay? That's what we really want to do. We want to keep the best workers, keep them, and hire ones like them. That's the goal. If we don't have a way to do that, I don't know if we can keep the best ones, and we end up with workers. Shifts will be staffed, but are they best workers? And the goal is the top right-hand quadrant, high change. I acknowledge there's needs changes in the waivers. I think we had 11 recommendations. We talked about it earlier when the cabinet did it with Deloitte in the late 2016, 2017. We want to make changes, but we got to go forward with understanding that those changes will be priced, and we'll figure out if we have to do it incrementally, how we do that based on the budget number. Otherwise, we're going to have struggles if we just make change without dollars. And those are just a summary of those 4 slides. Again, we want to support individuals today, folks on the waiting list, and folks we don't know about. Because there's people out there not on waiting lists that we have to figure out. I believe, again, SMI waiver. It's the 3rd time I've said that. Hopefully you walk away knowing SMI waiver. Or I haven't done my job. I think we can figure this out. I really do. I think we have enough people around in the room who can do this. We've got to balance the needs of all players. We want to participate. We want to move forward. That's all I have. How'd I do on time?
You did great on time, Steve. Appreciate it. We'll see if we have any questions. Senator Meredith has a question.
Thanks, Steve. That was a good presentation on your part, very eye-opening. I think we can have some more discussion on this budget neutrality. I get what you're trying to get at. That's probably not the right term. We may have to invent another one, but I still think we got to recognize that what we're not doing right now is costing us money.
Yeah.
But we don't know how much. So I'm hoping maybe what you're saying is that on the front end, we need additional revenue to bridge until we can get where we need to be, and there could be some reduction. So can we be in agreement on that?
Sure.
That's fair.
I reserve the right to perhaps 5 years from now, Senator Meredith,
right,
revisit it.
All right. I like the idea of doing it incrementally. And I look at Pam because I don't want to scare her here. You know, you may be really married to this thing, but I think there may be some merit with that. But I'm just curious as which area you think we need to focus on first.
I think, one, we got to talk about workforce. We have to talk about workforce. And other folks are sure going to raise that issue. We work really hard to get people in place. But in reality, some aren't very good employees, and they don't last very long. Yep. I think we got to focus, and that goes over the PDS program as well. They need competent workers. So we got to have a good, solid workforce. And we have to be in a position to give people hope of a pay increase. It has to be that. Otherwise, they're going to go someplace else. So I think workforce is one. I think if next is the waiting list. Is there a strategic approach? You know, I go back too long. 2000, there was people on the waiting list for SEL for 7, 8, 9, 10 years. And we started moving towards that. Okay? We made that commitment over time. We have to figure out that piece as well. Those two things, I think, is where we have to get to and then go forward. And I like to see the data comparing us nationally, because maybe we're doing things other states aren't doing. That's my first answer, is that maybe we're better than those states. So, how was that answer?
Not too bad.
All right.
Yeah.
Okay. I'll take that.
I appreciate it. Thank you, Mr. Chair. That's all I got.
Thank you, Senator Meredith. Senator Carroll.
Thank you, Mr. Chairman. And this question's probably more directed towards the chairs. With this task force, what is our goal, and how far down in the weeds are we going to get with this? Because to really make informed decisions, I think there really needs to be discussions on each service that is provided, and we need numbers related to each service. When you get into Michelle P. and you get into the juvenile population, getting those services, there aren't even services available for adult daycare or adult day training for juveniles. So that is a service for Michelle P., but yet a 12-year-old kid can't get that. And I'm not even sure we're going to test that, because we're going to be opening up a summer program, basically a juvenile ADT program.
Nice.
And, is Medicaid going to cover that? Is the waiver going to cover it for those kids that have it? But right now, as far as I know in the state, there is nothing like that. So for us as a group to really make informed decisions, this gets much deeper than what you all heard today. And there are so many different variances for let's say for someone that does CLS with a Michelle P. Recipient. At our organization, we pay $14 an hour for someone to do that. My daughter has Michelle P. waiver. She's on PDS. We're able to pay $20 an hour to the people that work with her. So those are just some of the details at so many different levels that you can get in with this. So my question is, as a task force, what is our plan moving forward, and how deep are we going to get into these services to really be able to understand it? And I don't know that we'll have time during the interim to really do that.
Well, I think obviously we're looking at this a 6-month period, and I think we need to do as deep a dive as we possibly can do in that time frame. And like you say, this can go so many ways with so many variables, and I think we've just got to dig in as deep as we can and see where we go from there. Senator Adams, do you have any comment on that? I think Senator Adams is stunned. So,
well, I do think that there are some critical issues that have been identified, and the waiting list being one of those. But I really think we have to identify where the weaknesses are in the waiver services, and what are the ones that we can adjust, and perhaps more savings or more efficiently, or different types of services. And, I know the commissioner and Pam have thought far more about this than I have, but I just think there are a lot of different areas that we can look at that we can make a difference in, and maybe we need to prioritize where those are with workforce, with the waiting list, those types of things. But it gets very complicated, and there are some inequities. The Commissioner and I have had this conversation with some of the other programs. There are some true inequities for the same types of services. But with that being said, there are some providers that rely on those inequities to survive. So just understand that as we move forward, for everything we look to solve, that solution is going to create a problem for somebody else. And I'm sure that's with the reviews that have gone on. I'm sure that's been standard across the board with every time the waivers have been reviewed.
Okay. Thank you, Senator Carroll. Any other questions we have from you?
Mr. Chair, just a quick comment. I think Senator Carroll's comments leads credence to that recommendation about doing the redesign incrementally rather than all at once, because this is tough. I don't relish your job at all and wish you the best. And
26,000 people lives are affected by what happens here.
yeah, and it's like how many people can you get in the lifeboat at one time? It's just tough to do, and I'm afraid if we take too much on at one time, then nobody succeeds. Where if we can do it incrementally, maybe that makes sense. But again, I think that's part of the reason for this task force. We had this discussion, but I appreciate what Senator Carroll has said.
And I'm assuming, Steve, that number of 26,000, then you add on their family and others, so it actually impacts more than
Yes.
26,000 people.
Right. Without a doubt. Correct.
Mr. Chairman, if I might, just real quickly, I almost think that before we really look into other areas, that maybe the best place to start is where do we find the savings? And, I think a review of all of the waiver services has to come before we do that. And then we look at where are the places to find the savings. With the juvenile population, again, how many respite hours are used by that population? Is that, being, with or without a disability, that's what you use granny and uncles and aunts to babysit. So how many hours are being spent for these children with respite? Is there a savings to be had there? And maybe look up front, what are the areas where we can find the most efficiencies so we can kind of know what we have to work with moving past that. And that's just a thought. And these thoughts come from having gone through this personally with my daughter, with our daughter, and then with the center, with the adult population, and then as a provider also the frustration of getting calls monthly from parents of those from 12 to 16 that don't have anything during the summer months on a daily basis, and that's where the struggle comes in for them mainly. So there's just a lot of issues with whatever age group, from the young kids to the more seniors, that the issues are different with each age group. And I'm sorry, I'm getting way too far with this, but these are the things that keep me awake at night.
Yeah.
Thank you, Senator Carroll. Steve, we appreciate your report. Thank you very much. And our next presenter is Amy Stade, Executive Director of the Kentucky Association of Private Providers. Please make your way, Amy, please make your way to the table. Once you are ready, please introduce yourself for the record, and you may proceed.
Hi, can you hear me?
Yes, we can.
My name is Amy Stade. I am the Executive Director of the Kentucky Association of Private Providers, and I'm going to try to go through this quick. Thank you for allowing me to be here today. CAP is a trade association representing providers of services to individuals with intellectual and developmental disabilities. Generally, this is through the Supports for Community Living waiver and the Michelle P. waiver, but individuals with disabilities also get services on a certain extent through the home and community-based waiver. Statewide, CAP members support around 10,000 individuals with intellectual and developmental disabilities and employ over 9,000 direct support professionals. Before I begin, I really just want to thank Commissioner Lee and Director Smith just for their hard work on this issue. They've really been willing to listen to stakeholder feedback. When they came in and, they paused the rate study and have really wanted to work on this. And I commend them both for that. Briefly, I just want to talk about the waivers. You've heard about all of them, but I did want to take a chance to explain the difference a little bit between the Michelle P. and the SCL waivers. So the SCL, yes, we serve the same population, generally speaking. On the Michelle P. waiver, you have individuals who either live with a family member or can live independently on their own with some support. On the SCL waiver, we have generally, most of these people are actually have state guardians. They generally don't have a family that they can live with. And the key is they really need that residential piece that's in the SCL waiver. They can't live by themselves, and there's no family for them to live with. They need that residential care for the SCL waiver, and that's generally why they're on the SCL waiver. Also, these folks don't have private insurance, so we are just talking about Medicaid funded here. 1915C HCBS services, they're an alternative to institutionalization. They allow individuals to live safely in the community. They are cost effective. I won't talk about that. That data is outdated. I did want to kind of, again, just talk about exactly how much we're spending in our waivers. If you look at the state share for SCL, and this is 2019 data, I chose that because it's non-COVID data. I figured it was the costs were a little bit more accurate. SCL, our state share, is about $116 million. In Michelle P, it's about $102 million. Note that Michelle P waiver services are limited to 40 hours a week and an annual expenditure limit of $63,000. So in January, new data came out from the Centers for Medicare and Medicaid Services, actually, that compares Kentucky nationally to kind of illustrate what we're spending. So nationally, long-term support services account for 32% of national Medicaid expenditures. Kentucky's long-term support spend only accounts for 21% of our Medicaid spend, and this places us in the bottom 10 of all states. The national average per resident for long-term support spend is $522.44. Kentucky's well below the national average at $468.30. Nationally, HCBS services, which is what we're talking about here, our 1915C HCBS waivers, accounts for 56% of all LTSS expenditures. Kentucky's HCBS spend accounts for only 42.8% of our long-term support services spend, which places us in the bottom quartile. We're in the bottom 25% of all states with our spend. The national average per resident HCBS spend is $298.18. Kentucky's average per resident HCBS spend is $200.21. Nationally, 72% of all 1915C waiver spend is on IDD services. We're a little bit higher. We're at 74% of our spend, but still kind of within that national average. We're middle of the road there. Additionally, Kentucky's per enrollee spending for 1915C waiver services for individuals with IDD is slightly below the national average. The national average is $46,000, $46,300. We're at $45,300. And if you compare that, we're also below for seniors, but we are well above the national average for medically fragile and technology-dependent children. The national average is $35,000, and we're at $66,300. So there's been a lot of conversation about quality and what are we getting for our money. And I just want to say from the outset, the waivers are the cost savings. With this population, we would be supporting them and providing them 24-hour care no matter what, except it would be in an ICF or a nursing facility. If we're in an ICF, this care would cost us $1,200 a day. With the SCL waiver, we're at about $215 a day. So if you look at 365 days of care, an ICF would cost about $438,000 per person compared to that $45,300. So the waivers in and of themselves are the cost savings. We have to provide this care to this population no matter what. It's just now we're coming to the point where we choose where we're providing the care and how we're providing the care. And I would, remind members of this task force that the Olmstead decision requires that states provide community-based alternatives for these kinds of services. And we definitely don't want a DOJ investigation in our state about not providing community-based care. Additionally, Kentucky, we've increased our waiver spend from 2007 to present, and Kentucky has increased our case for inclusion ranking, which kind of rates states about how they're providing these services, the quality of the services, etc. Our ranking has increased from number 40 to number 5. So our investment has really, truly improved the quality of services we're providing in the state. I'll kind of go through these quickly. We have comments just specifically about the SCL and the Michelle P applications. I want to be clear that these comments relate only to the SCL and Michelle P waiver applications. While they may apply to other applications, they are limited to the SCL and Michelle P waiver applications. So in the applications, the service definitions, processes, all of that, it's vague. So essentially, it's impossible for a provider to accurately evaluate how the proposed changes are going to affect them unless we see the regulations, because these regulations drive the program. And we have no idea if, the service definitions or the rates proposed are actually going to be sufficient to sustain the system unless we can see the regulations. Implementation of the waiver applications as written and the proposed rates as written will result in individuals with IDD experiencing a reduction in services. In our waiver application, it specifically states that the intention and availability of service do not change. Therefore, the Department for Medicaid Services does not anticipate that participants will experience a reduction in service. Ultimately, the reduction of SCL and Michelle P service reimbursement and the reduced service limits proposed in the applications will result in participants experiencing a significant reduction in services. Further, it will make it impossible for providers to adequately provide and coordinate program-wide supports that address the needs, conditions, and/or symptoms, which will negatively impact participants' ability to participate fully in his or her community. We have service-specific comments. You have them in your packets. I won't go through them, but if you're curious, they're in there. My next comments are related to the Navigant rate study. These apply probably to all waivers, but again, my comments are limited to the SCL and Michelle P waivers. The rate study was not transparent. I served on the rate study work group. We were not permitted to share information. We were not permitted to talk about information outside the work group. We couldn't solicit stakeholder feedback. So it was just 8 people in a room trying to figure out rates for an entire system of care. The stakeholder feedback was not there, unfortunately. Stakeholders were not given time to respond to the rates. The proposed rates were released to the rate study work group on August 21st, 2019. Then the proposed rates were released to stakeholders, the general public, on September 17th, 2019. Stakeholders were given 8 business days to do a financial analysis and determine how the rates would affect them before the rates were submitted to CMS for approval. The proposed rates are based upon the current service definitions and allowable units, and don't actually relate to the new proposed service definitions and the new proposed units. Also, the proposed rates are based on 2018 cost data and are now outdated. They don't reflect the actual cost of doing business, but instead reflect the strict budget neutrality parameters that were placed upon Navigant. And when we talk about budget neutrality, CMS does have a requirement of cost neutrality in that Kentucky cannot spend more on our waiver services than we would on institutional care. There's a lot of wiggle room there between the $1,200 a day that we would spend on institutional care and the $215 a day that we spend on the community-based care. And I know that a lot more factors go into it, but we do have wiggle room. We can spend more money, and CMS would approve it. It is a possibility. Additionally, these rates they were based upon a 30% response rate to the cost survey. So only 30% of providers responded. Also, the rates are based on Bureau of Labor Statistics data to use for direct support professional wages to factor that into the rate. Unfortunately, the Bureau of Labor Statistics does not track direct support professional wages. Those data points don't exist. So they use things like nurse aides, etc., to compare those. And those are not similar jobs. They have different responsibilities and they have different rates of pay. Additionally, there is a national direct support professional wage crisis in the country. The wages are low across the country. So they based the wages off of artificially low wage rates across the country because they're all Medicaid reimbursed. And then additionally, they tried to create, with the reimbursement, parity across the waivers, which we agree with. If a service is the same service and is provided in 3 different waivers, it should be paid the same, if you're doing the same thing. Unfortunately, they did not consider the provider tax. And one waiver pays a 5.5% provider tax off of gross receipts. That is the Supports for Community Living waiver. No other waiver pays that. So if we're paying people equally, the SDL waiver providers automatically make 5.5% less for the same service. So outstanding issues that we believe that need to be addressed by the task force. Number 1 is workforce. I testified at length about this before A&R and the BR sub on Health and Human Services at the beginning of the month. It's dire. We are at a critical level. And the key with the workforce is we're only going to be able to solve it with money. These providers have no other income stream. They can't go out and increase the price of the hamburger so that they can pay their employees more. The only way they're going to be able to pay their employees more is if we increase reimbursement rates. And I'll tell you, the federal government is likely going to increase the minimum wage pretty significantly here soon. And these providers aren't going to be able to keep up. They already can't. They're already paying less than Walmart, McDonald's, fast food restaurants, Starbucks. Our reimbursement rates in general, I think we need to definitely take a look at the Navigant report. As Chair Riley will remember, we've got a lot of things to solve with the exceptional supports, and we've got significant gaps in care that exist also in the ABI waiver, in that we have individuals with often dual diagnoses that the waivers just cannot support right now. And we've got to figure out a way to support those populations. We need to address the SCL and Michelle P. waiver wait lists. We also need to address supports through a lifespan. So as we kind of touched upon, the Michelle P. waiver and the SCL waiver serve a similar population, and we need to figure out a way to easily transition individuals between waivers to support them to the best of our ability in situations like that. So, example, if someone's on the Michelle P. waiver and needs housing quickly, we need an easy way to get them an SCL slot so that they don't experience a gap in care. Also, we just need to take a look at our regulations. As I said, these services are 100% regulation driven. And right now our regulations focus a lot on documentation, entering data, etc. And it takes a lot of time away from just actually providing the care and making sure people are cared for. And so anyway, we can take a look at that. Here are my specific recommendations. Number 1, we need to address our immediate workforce crisis by implementing rate increases targeted to direct support professional jobs and those services across all waivers. That's got to be done today. I understand that we can't today, but we need this money just to keep waiver services afloat. Number 2, we need to implement a long-term funding solution based upon accurate data to establish a sound rate structure that includes a wage component that is adjusted for cost of living regularly. To Senator Carroll's point, I think it is a possibility for this task force to extend itself into the next interim, and we would support that, to take a real look at the rate structure in next year. Also, we would propose to revise regulations to allow for flexibility, innovation, and true person-centered care. We would make certain Appendix K changes permanently. There's been a great deal of flexibility that was afforded during the state of emergency under our Appendix K related to just flexibility with telehealth, and providers really, despite the challenges, extreme challenges facing them during COVID, they've really thrived from a care standpoint and have been able to be innovative for the first time in years, because just some of the stringent rules have been relaxed and they've been able to be truly person-centered and provide the best care possible. We need to address the SCL and Michelle P. Waiver waitlists. The Michelle P. Waiver waitlist needs to include emergency and urgent categories like SCL. We need a way to essentially triage some of these individuals on the waitlist. We're exploring if this is a possibility, but if it is, we need to allow for immediate reallocation of a slot when an individual dies. As Ms. Smith alluded to, if right now when an individual dies, you have to wait till the waiver plan year renews, which can sometimes be an entire calendar year almost, to reallocate that slot. So if we would also support that change. We need to address the gap in care for individuals with significant support needs. We had a lot of recommendations in the Exceptional Supports Task Force related to that. And again, that gap in care exists in multiple waivers. It's not just the SCL and Michelle P. waiver. Overhaul the referral and involuntary termination process so that individuals do not remain with providers who are no longer able to support their needs. So right now, for example, if a residential provider has an individual who's having extreme crisis, extreme behaviors, is a danger to self and his or her roommates, and that provider, calls the state and says, we don't have the resources to keep this individual safe and his or her roommates safe. That provider sends out a 30-day termination notice. But the thing is that that provider has to continue to support them until someone accepts that referral. And that could be years that individual is living in an environment that is not suited for him or her and is creating behaviors. It's not safe for roommates. And so we have to figure out a way to address this so that individuals do not have to remain with a provider that cannot support them anymore. So that's it. I kind of ran through it. Does anyone have any questions?
Senator Meredith.
Thanks, sir, and thank you for your presentation. I think everyone would agree that we've got to see the workforce issue addressed. I'd probably take issue with your statement that we are going to see a federal minimum wage of $15 an hour. I don't think it's going to happen. If it does, Kentucky's going to have a whole lot of problems that are going to exacerbate this even more, because bear in mind, 60% of our economy is based on small business in Kentucky, and this will devastate them, and there goes the tax revenue. We need to do this. I think the best statement that you've made so far is that waivers are the cost savings. I think we do have to keep that central to this discussion. But I think what's missing is we don't know how much potential there is for additional cost savings if we do the very things you're talking about. And that's where I think we need a really deep dive to see where this is going to be. And it goes to Steve's presentation earlier about, if we need to provide additional funding to make this bridge in order to provide these additional services under the waiver program, then I think that may be the focus and what we could do most immediately, but we don't know what that is. But I think there definitely is tremendous savings potential there, but we have to identify that cost. Also, even though you are the cost savings, you noted that if we modify the regulations and make them more flexible, and I'm all about that, always have been, that there's a savings there as well. And I think it goes back to Pam's presentation earlier that, we build more accountability into the system. That helps us all. So I think we have to address this on additional fronts. But to me, what should be the priority is how much potential is the savings there by expanding the services and not just look at it as a cost center, but a savings center. But again, accountability within your cost savings for this entire program. So I'm with you. But again, I think we really need to focus on where's the potential savings to the Medicaid program by expanding these services and then attempt to try to do something immediately. So thank you. Appreciate your presentation.
Thank you, Senator Meredith. Senator Carroll.
Thank you, Mr. Chairman. Amy, thank you for the presentation. Can you talk a little bit about the IDD population in relation to how expensive it is to care for this population? And is Kentucky really an anomaly in that area, or are we pretty much in line with the costs throughout the country?
So we are in line. Nationwide, states spend about 70% of their HCBS budgets on caring for individuals with IDD. It's expensive. I'll just give you the lifespan of someone with IDD. An individual generally can come onto the SCL waiver when, let's say, 21 years old. For the rest of their life, they are going to be cared for on the SCL waiver. Despite the amazing care, 9 times out of 10, someone's intellectual disability will never improve enough for that person to live by themselves and maybe be on the Michelle P. waiver. It does happen, and it's amazing, and that is a testament to our amazing waiver providers. But generally speaking, this is a lifetime of care for this individual, and there's just not a lot of ways around that. And that is why this population is so expensive to support. Additionally, a lot of people with intellectual and developmental disabilities have some health problems. Some of them have co-occurring mental health issues, which makes this all the more complicated. And so it's just a complex population, and it's a complex population nationally. It's not just Kentucky that's experiencing this.
And then one final question: from what you're seeing from those that you represent, are we starting to see a greater use of the adult foster care? I think it's called something different now. Adult
Family home providers.
Family home providers, FOP, yes. And the acronyms change all the time, and I can't keep up with them. Are we starting to see that utilized more across the state?
Yes, so especially in larger cities, and that has come about because residential providers in the staffed residence model could not afford to pay. For example, in Lexington and Louisville, $15 an hour has kind of become standard. That's just the going rate right now, or around there. These residential providers, the rate does not support that wage, and so they had to look at other care models. The family home provider and the adult foster care model utilizes independent contractors, so obviously there's not the overhead is not there, and they all have different contracts to pass through, a certain amount of reimbursement. That has been a great service for a lot of individuals, and it is expanding in the state. Not everyone, though, is appropriate for that service. Some individuals do need the staffed residence model with more oversight, et cetera. It's just, whatever. It is suited, though, well for a lot of individuals.
There are a lot of struggles within the staff residence model. Are those numbers declining across the state?
Well, we are seeing some who have gone out of business or are selling to larger national corporations who have the cash flow from other states to support higher wages for those, which is sad. I hate to see Kentucky businesses, go out. Additionally, the staff residence model is declining, and it's unfortunate because a lot of individuals in the Sports for Community Living waiver do need that level of care, do need, the true 24-hour care that we get with the staff residence model. The family home provider is a lot more flexible, more family like environment, etc. And it is great. But yeah, and a lot of it has to do with the wage piece with the staff residence model.
Thank you, and appreciate all your work.
Thank you.
Thank you, Senator Carroll. Amy, we sure do appreciate your testimony today.
Thank you.
And at this time, we will ask for our last presenters for this afternoon are Diane Shermer and Mary Haas with the Brain Injury Association of America, Kentucky chapter. Ms. Shermer and Ms. Haas, please make your way to the table. Once you are ready, please introduce yourselves to the record, and you may proceed.
Which one?
I'm the chair of the Brain Injury Association of America. Do I need to start over? Okay. Thank you for having us. My name's Diane Shermer, and I'm the chair of the Brain Injury Association of America's Kentucky chapter.
And I'm Mary Haas, and I'm with the Brain Injury Association, and I've been an advocate for individuals with brain injury for the last 28 to 30 years. So thank you, and thank you for having us.
So we want to start by saying that we want to commend the Navigant team's effort to consolidate leadership of waiver operations and administration and streamlining processes across the waiver. We concur that many administrative items across the waivers should be standardized. However, the one-size-fits-all approach to care loses the most important focus, which is the person being served. If you were diagnosed with breast cancer, would you like to be told that your care would be directed by an orthopedic surgeon or perhaps a urologist? The report cites national trends and best practices repeatedly. However, there are no evidence-based best practices cited pertaining specifically to brain injury or any other specific disability group. In fact, there is a recommendation to reduce services in the ABI waivers, which we strongly oppose. The fact is that rates have not increased in well over 10 years, yet inflation and costs of providing services have continued to climb. Medicaid waiver providers are charged with caring our nation's most vulnerable individuals, yet rates don't allow wages to be competitive, and you've heard this from all of us this afternoon. I'd like to talk a little bit specifically about brain injury because it seems to be that everybody wants to lump it together with all the other categories. Brain injury is not a one-time event. It can be a chronic condition that impacts an individual throughout his or her lifetime. 5 years post-injury, 30% of individuals will evidence a decline in their levels of ability that they once attained 1 year post-injury. Additionally, 5 years post-injury, 1 in 5 individuals die. Life expectancy, we now know, is shortened by 9 years for those who sustain a moderate to severe brain injury. And we also know that there is an increased incidence of disease progression akin to Alzheimer's disease noted in this population over time, hence the chronic condition that we see. It's sad to say that our statistics are from 2014, but in 2014, Kentucky had over 32,000 TBI-related emergency department visits and over 3,000 hospitalizations. Many of these individuals experience a lifelong disability that develop comorbid conditions such as psychiatric illness, substance abuse issues, and other issues that will keep them from maintaining a quality of life and work that we take for granted. Our current waivers, which have not been revised in over 20 years, distinguishes an acute and long-term category. All of these individuals have brain injuries, and if these categories cannot be changed, they must be expanded to include individuals who are considered to be medically complex and neurobehaviorally challenged, with rates for services adjusted to based on the individual needs. Typically in brain injury programs across the country, there is a continuum of services that extends from the acute to the community-based services. I'm a CARF surveyor, which is the Commission on Accreditation of Rehab Facilities. CARF accreditates programs across this country and probably 12 to 15 other countries. And unlike other programs in behavioral health or perhaps for cancer care, when you go for brain injury specialty, which differs from stroke, you have to have the full continuum. So if you take on brain injury and you say, I want to do acute brain injury, you have to show that you have the full continuum services, which means you go from acute all the way through community-based services. Additionally, there is a need to expand clinical expertise regarding brain injury in the department and among providers, expertise which is essential to properly assess a candidate for services and to provide guidance and expertise to waiver providers to help Kentucky stay current with evidence-based brain injury rehabilitation practices. A week ago, we had a conversation with many people at the state level to talk about how case managers were struggling with getting people into the waiver system. And it was because they were thinking they needed a scan to make someone eligible for services. We were told in that meeting that that was just a training issue, that was something that needed to be retrained, that scans were not needed. So we provided information to the state to list the people that were involved in that so that they could do retraining. About 2 days later, I had a call from 2 case managers who said, but yet I've been told by the state that the documentation that I submitted is insufficient, that I need to give a scan. So where's the training needed? There is also a need for comprehensive standardized training for personnel working in the waivers that should be evidence-based and ongoing. Whether you work in Paducah, Lexington, or in Bowling Green, there should be standardized training that all of us as providers providing services to individuals with brain injury should have. It should be consistent across all of us. One example of this would be considered the Academy of Certified Brain Injury Specialists. What makes brain injury unique? Our roots are deep in physical medicine and rehab. This is not just a physician. It means that we are slated in physical medicine, which involves therapy services as well as the team that provides the services and the care that we provide. It's an interdisciplinary treatment team in which all members provide a coordinated effort toward a central goal to benefit the person served. The team brings a diversity of expertise to benefit the individual being served. That may include physicians, clinicians, rehabilitation and general practitioner nurses, skilled therapists, direct care staff, and many other unique providers of brain injury services. The whole program is person-centered. Rehabilitation therapy is delivered in the context of real-life situations in a home and community-based service, whether that's discharge from the hospital or in post-acute settings, such as a residential or transitional program. These services include activities of daily living, including self-care, community mobility, transfers, problem solving, functional mathematics, therapeutic recreation, and other services to enable independent living. An example might be someone who is 4 years post-injury but still has post-traumatic amnesia. That individual doesn't remember who his therapists are on that given day, any day. He still doesn't remember what he had for breakfast, so you have to help him remember. My dad had a brain injury after I started in rehab, and 5 years post-injury, when his wife took him to Walmart to go grocery shopping, he wasn't allowed to drive. He went to the bench to wait for her while she finished shopping. He thought she left, so he picked up a cab, and he gave the cab driver their address, what he thought was their address. It was his previous address, 20 miles outside of Houston. When he got to that address, he had no money to pay for the cab, and so he became belligerent with the cab driver. Also, other people were living in the home, which he couldn't understand, and so then he was taken to the jail. I was the emergency contact in the wallet. In the meantime, his wife was hysterical, having police look for him. That was 5 years post-injury. That's what brain injury is every day. The core of brain injury also is in cognitive rehabilitation. Cognitive rehabilitation therapy is the basis of all that we do in brain injury rehab. Cognitive problems change over time with individuals with brain injury and may evolve at a different pace for each person, with many interacting factors that affecting initial recovery and recovery over time. Cognitive disorders make it difficult for individuals with brain injury to monitor changes in their daily routine, their daily health, or to even comply with their medication regimen. Cognitive rehabilitation is a systematically applied set of medical and therapeutic services designed to improve cognitive functioning and participation in activities that may be affected by difficulties in one or more of their cognitive domains. Our outcomes are done through rehab teams across the country when we focus on increasing function after illness and injury. The team develops a series of functional performance indicators and targets just as we set measurable goals and objectives for those we serve. We love to graduate individuals from our programs that have regained some quality of life again. There's nothing more rewarding to us as we watch somebody walk out of our program to regain some degree of quality of life. And actually, we have someone who just moved out of state after graduating from the waivers. However, there's also a need for these individuals to be able to process or transfer from an acute waiver to a long-term waiver, or as the others who have spoken, to move from one waiver to another. That should be in place.
Okay.
Mary?
Thank you, Diane. A couple recommendations, or actually I would say suggestions, that we would like to see this task force take on. And I know you already heard from Amy and from Steve. It's the workforce. I mean, all of us who drove here today seen $15 an hour sign, now hiring. I'm going to put it for real with my sister. In the last 2 weeks, she has had 3 different caregivers. And it's very upsetting to her because she thought those were her friends. They were somebody who was providing her direct needs every day. And she says, why did they leave? Well, they left because they could make more money. The one provider, they're paying minimum wage, and it's 7-something an hour. And somebody correct me if I'm wrong here. But, you know, you're looking at McDonald's, you're looking at Starbucks, they're paying $15 an hour. Again, what the amount is, I don't know. I just know in real life, it's upsetting when you're trying to provide that consistency and someone who's telling her when she gets up in the morning, you have to shower, you have to take your medicines. So that's real life, what not having that workforce that we can depend on and value the people and our most vulnerable, that I know everyone in this room that we want to serve. We want to serve them. We want them to have that quality of life. I think Amy spoke about Appendix K. Again, making these changes flexible for all providers. And going back to Senator Meredith, I do think there could be some things where we could relax some regulations and get some efficiencies and things that we want to be involved in this process. And anyone knows me, I'll do whatever it takes to make this go forward and to really serve the people we all care about. person-centered. I know we've all said this too. Again, and I've talked to Pam on many occasions, we want this to be person-centered. One size does not fit all, because there is no two brain injuries alike. I've spoken with many families. One person who has had a very severe brain injury, their son's back working, doing what we all want them to achieve. We have someone else who maybe what would be considered a mild brain injury. They will never be able to live on their own. So that's what's different about ABI. And probably all our disabilities. I don't want to just section that, because this is all about serving all of our people in the waivers. Gaps in care. Address the issues relating to the gaps across all the waivers, such as patients. And one of the things that's near and dear to my heart is neurobehavioral. I think that's one thing when we say, well, right now we don't have a waiting list for brain injury. Well, that's because we're not able to really serve those neurobehavioral clients. A provider's just not going to be able to provide the care that they're going to need to sustain them if we have somebody who's truly behavioral challenged. The good news is it's not a big percentage of our population, but it's probably our most in need part of the ABI population. Again, we've heard flexibility. Provide that flexibility for patients to be able to transition among the waivers. Again, I have some brain injury clients who are in SCL. You know, I had to have some ABI clients who are in Michelle P. Again, let's look at the needs. If we're really going to do person-centered, let's look at the needs, and if there's some ability, and I think Amy said it, if we can transition across waivers, that would be great. And again, short-term, it's funding. Provide a rate increase for the waivers to address the critical workforce issues. Long-term, implement a long-term funding strategy in the next budget designed to address our workforce crisis going forward and provide sustainability in all the waivers. And again, I thank you for your all's attention, and Diane and I are welcome to any questions you may have. Thank you. Thank you, Representative Riley, and if Julie's on the thing, thank her also.
Thank you so much. Do we have any questions? Senator Meredith?
Thank you for your presentation. I've got two brief questions, and they're more global in nature. What's the primary cause or source of traumatic brain injuries?
Well, it could vary. It used to be motor vehicle accidents, but right now we're seeing an increase in falls with children. It's falls. The other one is violence. Diane and I both work with individuals due to, they suffer their brain injury due to domestic violence. I mean, I don't know if you have any more national. Diane does more on the national. I would say in Kentucky, it's still motor vehicle and gun violence.
And actually, the leading cause of traumatic brain injury would vary by state. In Oklahoma, it might be that you're kicked by a horse. But nationally it is falls, and it's because the group that's getting injured most by TBI is many of us in the room, the aging population. The older American is actually falling. So we are the leading cause. For children, it's actually a combination of falls and actually bike and motor accidents. Motor vehicle accidents.
And do you have any statistics that show Kentucky's incident rate compared to national average?
Not right off the tip of my finger, but I could get that for you.
I'd appreciate that, because one of the things I think could influence this is, and we'll be talking about it in one of our committees. I'm sorry, I forget which one committee involved, but the lack of a trauma network in Kentucky, and we funded that many years ago, but never have. We approved that many years ago, but haven't funded that either. And I'm looking to see if that could potentially impact the situation as well. So
we'd love to talk about trauma network, and actually, TJ's bill is something that we support too for bike helmets. So
I've heard of that. Yes. All right. Thank you very much.
Thank you.
Senator Carroll.
Thank you, Mr. Chairman. What are the services?
There's 16 services, and I probably have to defer to Pam to specifically name them all. Residential care is one of the leading services. case management, I think, is a very valuable piece, especially when you're dealing with the ABI population. One thing that's not available in the other waivers that is available in the ABI is the counseling, having the true counseling directed at the person with the brain injury. Again, the way you would set my sister up for counseling, because again, hers was due to domestic violence, so she also suffers from post-traumatic stress. So having someone skilled in the counseling piece that addresses both the ABI and the other dual diagnosis. A lot of our people do have dual diagnosis. I know Steve talked about severe mental illness. My brother was schizophrenic before his brain injury. So, again, a lot of our people are dual diagnosis. So I think the other service that people really appreciate in the ABI waivers is the therapies, is especially occupational therapy. And Diane actually is the one who provides the direct care, but again, my sister's a recipient. But again, the way you would set my sister up for occupational therapy, you may have to take 15 minutes at the first part of just reminding her of what you did in the last session or whatever. So getting someone with that PT is something, again, that is provided in ours. And help me out.
Yeah, occupational, physical, and speech therapy are therapy services typically provided for individuals with brain injury. And I think the challenging part to understand is, do they need them just at the acute stage or the long-term stage? And I understand the need for states to look at how many sessions to allocate, and sessions is a poor choice of word, because therapy services may be needed over a lifetime. Somebody needs therapy services perhaps when they're initially injured, but as they age, they may need them again. Or perhaps if they have COVID, they may need them for a short duration in recovery from COVID. There are many circumstances that change at that individual ages based on the differences that change in their body and the progression of their brain that will cause them to need those therapy services again. So they may need them periodically. And there's one thing that comes in with their therapy services, behavioral services through a certified behavior analyst. It makes no sense that the therapist develops the plan but doesn't touch the individual. That's not how it's written in for any clinician. They should be able to work with the individual. So that's something that should be changed. But I will support, and I do mean this, that many individuals can be given therapy, and you can also teach direct care staff to do many therapeutic activities with individuals. And the other thing that I want to say, since we're talking about this, is that day treatment is not meant to take 20 people on a bus to a room where they all go in and have someone direct them. I've been doing rehab for little over 30 years now. I started when I was 5. Day treatment is meant to have people work on skills that are their functional skills that they need. And that might be 3 people working with someone on cooking while 4 people go over here and work on mechanical skills. It's not putting 20 people in one room and they all do something together. And I think, unfortunately, somehow we've gotten there for a variety of reasons. And I'm not pointing fingers and I'm not criticizing. It's just that day treatment, whether it's brain injury or IDD, should be really directed toward the individual and what their needs are. The distinction that we've tried to make today is that rehab is really different. We are rehabilitating someone to get them back to a certain point in their level of function versus habilitative care. And that's the distinction we wanted to make. Thank you for that.
Thank you, ladies.
Thank you.
Thank you, Senator Carroll. In talking about brain injuries, my mom passed away about 3 months ago from a brain injury that she had suffered about 4 years before. I think I saw some stats you had that sometimes it's less than 5 years, and I think she's a little bit over 4 years. And you know, we've talked here a lot about the difficulties of workers, and a lot of that is because of pay. And a lot of it is because these jobs are extremely difficult. The ladies that helped my dad take care of my mom, those jobs, you know, taking care of your family members is one thing, but taking care of someone else suffering those things, it takes special people to do these jobs. It truly does.
If you could have been with me the day that I had to drive 20 miles outside of Houston to get my father at the jail, and also take my stepmother with me to help her explain that he had just recalled a previous address, you know, I can laugh about it now, but it wasn't pleasurable. And I can tell you that the first Thanksgiving that we celebrated after he came home from the hospital, he was so anxious to participate in the festivities. The only thing he forgot to do was turn on the oven, so we all ate pizza. Yeah. So.
Well, thank you, ladies. We sure do appreciate your presentation and appreciate what you do. This concludes our business for this afternoon. As a reminder, the next meeting of the 1915C Home and Community-Based Services Waiver Task Force is scheduled for 1 p.m. on Monday, July 26th. If there's no further business come before the task force today, this meeting is adjourned. Thank you, everybody.
Thank you.
Thank you.
Thank you.